Hello. This is a large class. It's my honor to be here to talk to you a little bit today about health psychology. What we're going to talk about today is just to put it in context for you, is this is different than what you've been exposed to so far in a number of ways. And one of the major ways is that health psychology as a subfield of psychology hasn't existed all that long. Maybe 30 years, 35 years at the very most. And so some of the sub-areas of psychological science that you've been exposed to so far, cognitive psychology, clinical psychology is still coming up, I think for you, and social is as well, but developmental psychology, they've been around for some time, really from the roots of the field. Health psychology is relatively new, and so I'm going to give you a sense of why it is that health psychology has developed as a subfield, why it exists today, and then I'll talk to you a bit about two of the major areas within health psychology, which is the study of stress, and then the study of how to get over stress, which is coping. And so we'll probably get into stress a little bit today by the end, and then on Wednesday, we'll finish up stress and talk about coping. And then I'll give you a flavor of what health psychology also offers. But this is a very, very large area, and it's you know, as with all the subfields of psychology, psychological science, you may have picked up, it's virtually impossible to kind of give you a really good sense of it in a lecture or two. But at least I'm hoping to whet your appetite in case you're interested in the area and you can take further classes. We have a 200 level class in health psychology, and I'll give you a sense of that. So we'll start off with by telling you why health psychology kind of has come to exist. Talk about stress a bit, models of stress, how you measure stress, the factors that are known to lead to stress, and then we'll talk about coping. And this, as I think with all the lectures in this class, this slideshow has been posted. It was posted, I believe, yesterday. So don't feel you need to write down what you want to write down, but all of this is available to you. So I need you to be able to think for a little bit beyond how you would normally think, just to get into the mindset of why we have health psychology today. I think there's an undeniable link, and we see this every day in the newspaper, between what we think, how we feel sometimes, and our physical body. And what you need to recognize is that there hasn't always been that sense that there's a connection between what goes on upstairs, what you're thinking, decision-making, feelings, perceptions, and how your body functions. It's hard for you to imagine that isn't always the way things have been, but it's not always been that clear linkage. And I'm going to spend just a minute talking to you about kind of the very core origins of that notion, that the mind, your consciousness, how you think, is related to your physical body. And we're going to start by talking about what's called the mind-body problem. And this is a major kind of conundrum within philosophy. And so if you've taken introductory philosophy, you may remember talking a little bit about this mind-body problem. And it's really at the core as to why we have something called health psychology today. Helps you to see why psychology is relevant to understanding physical health. What is the mind-body problem? It comes down to this question and the answer to this question. Are they separate things or are they the same thing? Is your mind, is your sense of consciousness that which defines you really, rather than the shell that it's in? Is it connected? Is it the same thing as the physical body, or is it separate? This is a philosophical conundrum. It's been around forever. I think we have an answer to it these days, but there hasn't always been an answer to the mind-body problem. And depending on how you answer this question, you either open the door to the role of psychology in connecting to understanding the physical body, or you close the door forever. The question's been around forever. Is the mind, and how is the mind connected to the physical body? We have evidence, even before we have written records from archaeological sites, that show precision holes drilled into the skulls of people in the same spot. And the archaeologist's explanation is that we think they were opening up some sort of channel by which evil spirits, maladies, bad things could leave the body, which shows us that there was probably, that even the earliest people, before there was writing, had some sort of sense that there's a connection between physical health and what's going on upstairs. We also know from the very earliest written records that people surmise that there might be some sort of connection between the mind and the body, going back to the father of medicine, Hippocrates, in 500 BC. So we're talking quite a while ago, 2,500 years ago. Hippocrates had his own theory as to how the body tended to operate and how the mind might be related to the operations of the body, called the humoral theory. It has nothing to do with something being funny. You know, humors, the term humors refers to fluids. It's base meaning. And according to Hippocrates, he believed that the body had different types of fluids within it, or humors, and that these fluids were related to specific personality types. And you don't need to know the specific fluids. One of them is blood, one of them is bile, there's a couple others. But the connection between the body and how people act or behave across situations, which we refer to as personality, was clear even way back when, 2,500 years ago. His belief was that when the fluids in the body, when the four fluids were balanced, then a person would be healthy, they'd be physically well. If those fluids, though, were not balanced, then disease would occur. He didn't specify the mechanisms by which any of this would work. It's kind of a general theory. But by linking parts of the body or fluids of the body to personality, automatically you can see a connection between the physical and the mental. His advice to people was to achieve what he called humoral balance. And humoral balance for him was have a good diet and avoid excess of all types, which is pretty much still the good advice today. And physical health was considered a bodily issue, certainly, but there was some undefined role for the mind, that somehow these fluids that are in your body were connected to how you acted across situations, or your personality, if you will. You could skip ahead many years, 700 years, up to Galen and Galen's germ theory. Galen was the first person to put out there, in writing at least, that the diseases we often see in people are caused by these really, really small things, which today we would call a pathogen, a foreign agent of some sort that disrupts the normal operation of the body. And it's difficult to understand how radical a notion this was at this time. No microscopes. We can't see anything smaller than what you can see with your eyes, right? And this guy's saying, guess what? I have this idea. There's these really small things, and they are causing diseases. And people are like, you're out of your mind, right? But of course, he was absolutely right. And Galen's notion, this idea that there are these pathogens out there, there's things kind of exogenous or external to the body that can get into the body and disrupt its normal operation. This represents, for a number of years, and still today, the dominant view in the medical world as to how the body operates and what disrupts the body. And Galen's germ theory was also fueled, and this notion of external agents being primarily associated with physical problems, fueled the philosophical work of Descartes, or Descartes, as my brother would say, or Descartes, it's properly phrased, the French philosopher, father of modern philosophy. Galen's views directly influenced Descartes' view of what's called dualism. And you may have heard of dualism. If you've taken philosophy, you've definitely heard of dualism. You may have just heard about it here and there. This is many years later. We're going way ahead now to 1600, now only 400 years ago. What is dualism? It's really proposing an answer to the mind-body problem. If you take a dualistic point of view, the mind and the body are fundamentally different. They're not necessarily even connected. Okay? They're different substances. The mind is non-material. It's non-corporal. Corporal meaning bodily in Latin. It's not bodily. He did believe that there might be a physical place, I could show this, in the brain where the mind, our spirit, our sense of self, interacts physically with the body. And he thought it might be in the pineal gland, which, if this will work, I could show you what it looks like, and you can see why someone, if you were going to open up the head and try to find a physical location for one's consciousness or spirit, or sense of self, you might say, yeah, I would probably go there too. Let's see if I can find right here. So if you were to open up somebody's head, look at the brain. The brain is incredibly spherical. I mean, it's very parallelism off both sides. Look at the very center. This right here, right there. According to Descartes, that might be the physical location where your spirit interacts with your body. Good a guess as any. We know the pineal gland has something to do with circadian rhythms. It doesn't necessarily have anything necessarily to do with consciousness, decision making, anything. But it's a good guess, I guess, if you're going to kind of point to some physical location. But if you basically believe, as Descartes believed, and as Galen kind of started that ball rolling, that the body and the mind are separate, then psychology is irrelevant to the physical body, right? If there's no connection, who cares what you're thinking or feeling? It has no effect on how your body operates. That view dominated medicine and psychology, really, for some 300 years, up until maybe 1950 or so, 1960 maybe, a dualistic view. And it gave rise to what's called the biomedical model of illness. Biomedical model. I don't know if you know what a model is. Obviously, I'm not meaning a airplane model or a runway model. When I say a model here, a model is a conceptual framework that provides a way of thinking about a topic. There are multiple models that you'll hear about in psychological science and in other fields, but it's just a way of thinking. So there's what's called a biomedical view or model or way of thinking about illness, which was fueled by Descartes' dualistic views. And the thing about a model is, once the model is accepted, then people tend to channel their thinking and their research and their energies within that kind of particular framework, within that particular model. And so that can preclude you from thinking beyond the model. And that could be one of the limitations of adopting a particular model as a way of thinking. What are the characteristics of the biomedical model? If you follow that model, which much of the field and the world has followed for many, many years, well, it is dualistic. It believes, from this point of view, that the physical and the psychosocial, or your sense of consciousness, your sense of self, that they're separate. It's a mechanistic view. That is, that the body is looked at as a machine, and the disease occurs, as Galen would have pointed out, when normal operation in the machine is disrupted by some sort of pathogen or foreign agent. You have this dualistic view. They're separate. The body is a machine. You can reduce the machine down to its working parts and find a specific area or areas that are the source of the problem. You don't need to look beyond that little circumscribed area. You don't have to look at the situation that a person is in, for example. You focus solely on one disease or one physical system. And it's disease-oriented. And this is very important. Health is defined as the absence of disease. So if you're neutral, if you're not really sick right now, then there's no problem from the biomedical model point of view. You only become a problem that needs fixing if you're somewhere a little bit sick, okay? We don't talk about being extra healthy or the concept of wellness, pushing you further away from being ill. And that's a major limitation, as you'll see in just a second. But from the biomedical point of view, it's a very disease-oriented point of view. The biomedical establishment doesn't consider there to be a problem until there is a problem. So there's something where you deviate from neutrality or from wellness. There's definitely advantages of this approach of the biomedical point of view. It's led to the development of incredible medications and vaccines, where more and more are coming out virtually weekly and have been coming out for years. Smallpox, for example, knocked off a lot of people in the past. It doesn't kill anyone today. And that's because of massive successes of a very biomedical point of view. Body's a machine, knock out that pathogen, look right at it, nail it, right? Done. So there's certain conditions that have been the great target of a biomedical point of view. Also, a number of new surgical procedures we never had, and they only were developed because of a biomedical approach. So there's nothing necessarily wrong with the biomedical approach. You're just going to see here that's very limited to the diseases that we tend to have today. Recent years have witnessed a challenge to the biomedical model due to some limitations with the model. And the biggest limitation I just pointed to, which is health seems to indicate the absence of disease within this model. But what about preventing a disease? We know without question that there's certain things people can do to prevent the onset of a condition. We know this. You can consider health as being on a continuum with illness or premature death on one side and exceptional wellness on the other. And I have a picture here of that, where at the middle here, you have the neutral point. So this is where there's no discernible illness or wellness. You're just basically okay, right? You're no better than okay, but you're no worse than okay. From the biomedical model point of view, it's all on this side over here. The biomedical model is all over here to the left. So basically there might be some signs of a problem, symptoms. You might have a disability, a short-term disability, a long-term disability. You might die. The whole goal is to get you as far away from death as possible. That's the goal. Death is the ultimate health problem you're trying to avoid. biomedical point of view is you take someone from possibly dying, you bring them up here, and you just drop them right there, okay? But you could certainly consider people going beyond just neutrality. You could consider that they could become more aware or educated or grow to know about things that are necessary to push them further from death. I mean, if death is still over here, heck, I would want to go further than this. I want to be over here, right? And we know things that would get people further away from health problems. And this led to this idea that, well, of course, illness doesn't have to stop at neutrality. This led to this a new way of thinking, a new model, if you will, of health and illness. And it's called the biopsychosocial model, and it's what has led to the rise of health psychology. We still have the bio in there. We're not throwing out bio, obviously. I mean, the biomedical model is incredible. But we do know that the psychological and social factors contribute to illness and to health, particularly when we've had such enormous successes from the biomedical approach in knocking out microbe-based conditions. There's still some left, obviously, but as you'll see with some charts I'll show you, we've had enormous successes. So people are living longer, and other things are contributing to bad health and to mortality in the end. And psychology has a lot to say about those conditions. So beyond the biomedical model, if you take a biopsychosocial point of view, we're talking about interplay, yes, of the biological, but also the psychological and social. Each of them are interrelated to one another. Each of them are producing changes in the other. And it's a very dynamic view of health and illness. It incorporates the physical, the psychological, and social. So why have we switched models from biomedical to biopsychosocial? Two big reasons why, and they're fairly obvious when you see them. The first is if you look at the pattern of illnesses that characterize adults throughout the world, particularly in the industrialized world, which includes the United States. So take a minute to absorb this chart. What we have at the bottom here, we have time at the bottom. So we've started with 1900, and it goes for the century, every 10 years. And then we have, along the left side here, we have disease mortality. And what we've laid on this are four different conditions. Okay, we have heart disease, we have cancer, we have tuberculosis, and we have measles and scarlet fever. Now you'll notice a couple of things, I think. Sorry. Two of the lines are going down, and two of them are going up. What do they have in common, the two that are going down, for example? Yeah, there's vaccines available, they're microbe-based. Right? Those would be tuberculosis, measles, scarlet fever. They virtually don't exist today. And the ones that are going up, anything in common? Heart disease and cancer. They're kind of cumulative a little bit, some of them. Some heart disease in general tends to be cumulative. It takes a while for you to eat enough bad foods that coat your arteries and restrict blood flow. Certain cancers take a while. If you smoke a cigarette, if you smoke a pack of cigarettes, there's no relationship in your whole life. There's no relationship to lung cancer. You smoke a lot of cigarettes, there's a huge relationship to lung cancer. It takes time, right? So if you're not being knocked off by some microbial-based illness, where life expectancy used to be 45 in the United States, 55. Today it's close to 80, right? If you're not being knocked off by things, you live longer, and we now allow for, really, conditions that take a long time to develop. They now can develop, and they do develop, and they eventually, we haven't found a cure to death, of course, but something's going to knock you off. And it tends to be conditions now like heart disease and cancer, which certainly have a genetic component to them, but they also have oftentimes a behavioral component. You don't have to smoke cigarettes. And if you do smoke cigarettes, we know there's a really big jump in the odds of your having lung cancer. It's not 1-to-1. So there's some people who smoke lots and they don't get lung cancer, but the odds of you getting lung cancer are much higher. If you eat certain foods, your odds of having heart disease go way up. Now, in psychology, we believe those are choices that you make, right? And we have models of decision making. You may have picked that up in the cognitive section of the course. So we know why people initiate actions. We know why, once they've initiated an action, why they would keep doing it. And so with that knowledge, we can apply it to understanding why people are doing maladaptive health habits, like, for example, smoking, which leads to higher rates of cancer, or eating poorly, which leads to higher rates of heart disease. That alone is one reason to look beyond just a biomedical approach, a reductionistic view that the body is not connected to the mind, because we know that there are behaviors that people enact which lead to physical problems. And behaviors are oftentimes mental. Here's another chart to show why this model switch. Really just look at the right side. The left side is just up there because I couldn't find an easy way to separate them. But on the right side there, look, this is deaths of all ages. This is the latest data from our U.S. Government, which is deaths through the year 2007, okay? All deaths. These are U.S. deaths. So the big picture to take home here is look at the right side of that circle on the right. Two conditions are responsible for about half of all deaths in the United States: heart disease and cancer, right? And a lot of heart disease has behavioral elements, and a lot of cancers have behavioral elements. Not all of them. I mean, I'm not trying to claim here that all of heart disease and all of cancer is behavioral. It's not. There's people who like eat incredibly well and are incredibly fit, and guess what? Their parents had stomach cancer, and they're going to get it too, right? So I'm not claiming it's all behavioral, but a large component of each of them separately is behavioral in origin. And that opens the door for thinking about how do we change people's behavior? How do we see linkages between behavior and outcomes and then potentially change that? And that's where health psychology comes in. And this, epiphany, which seems, I'm sure to many of you, exceptionally obvious, it just wasn't obvious to the field until the 70s, really. And health psychology as a subfield, as recognized within major organizations, really didn't emerge to the early 80s. So it's relatively new versus some of the other topics that you've been introduced to. The second major reason for switching to a biopsychosocial view is cost, it's money. Escalating cost of healthcare in recent years. I love this chart because it's like you don't get charts that are like that linear. I mean, this is like one of these perfect correlations between time and money. As time goes on, money just keeps going up. This one stops at 1998, but I'll show you a continuation in just a minute. But the take-home message here is we're spending a lot of money. This is just the U.S., but of course the world, you could extrapolate, it's the same. We spend a lot of money on health, and it goes up every single year, right? Here's another version of that. Just the cost of private health insurance since 98, where that last chart left off. It's going up quite a bit. Everything's going up. Out-of-pocket's going up. Everything's going up slightly, particularly the cost of private health insurance. Costs are going up. And the costs are going up because people are being treated for conditions. We have all sorts of technologies to treat the condition, which is great, but it's expensive. But certainly, wouldn't it be a heck of a lot cheaper to just not have people use the medical system to prevent the problem, right? And that's one of the bases for health psychology and for biopsychosocial view is let's get people further away from illness on that wellness part of the continuum so they don't enter the system because it's so expensive, right? So people are dying from different things that have behavioral origins, and it's really expensive to fix the machine when it's broken. So how about preventing the machine from being broken and acknowledging the behavioral origins to try to understand how we can impact people's behaviors. And I guess I want to be clear about something about impacting behaviors as well. The assumption is in psychology, or with psychology that has applied implications, that people want to do certain things. People may want to stop smoking, or they may want to know how to eat better, or they may want to know, what can I do so I remember to put on sunscreen so I don't get skin cancer? So the assumption is people want to know that information, and they may or may not use it. There is no assumption that that this should be imposed on people, right? Like we know what should be done, therefore you should do it, right? It's obvious that this is all within the calculus of choice. We assume people want to do these things. They may not want to, but that doesn't prevent us from wanting to gather the knowledge to be able to tell people, hey, this is what one would do if you want to prevent this. So as I mentioned, the cost of treatment spiraled. Much more of an emphasis on prevention because it ends up being cheaper. Behavior is, to at least some degree, and I would say to a large degree, is determined by what goes on inside your head, what goes on in the mind. Behavior isn't just a physical act. I mean, I'll do this. I'm not like an automaton. I'm choosing to walk, right? Certainly we do things habitually. We don't necessarily think about it, but we can break you out of that and then say, think about it, right? So I'm choosing to do that, right? So you see, there's all sorts of behaviors that people emit, and most of them are under cognitive control. And since we know behaviors are under cognitive control, we can start linking the behaviors that people emit or enact. We can look at those and figure out what are the cognitive, emotional underpinnings of those, and then change those to change the behavior. That would be a very applied way of looking at health psychology. Okay. I'm going to give you a quick quiz here, but I got to give you some background. So our behavior, it's not a graded quiz, so relax. Our behavior has a lot of impact on your health outcomes. A classic example is from this, what's called the Alameda County study of the 1960s. This is considered kind of the bedrock original evidence that led to really the rise of public health and models of public health, and it's one of the bedrock studies for health psychology by Bellick, Breslow, and colleagues. Does anyone know where Alameda County is? What state? California. Where in California? North, south? North, right? So it's Northern California. Alameda County is the county that's in the eastern bay of San Francisco. So San Francisco's kind of on a peninsula, you go to the Pacific, and then there's a big bay. On the inside of the bay is where Berkeley is, where Oakland is. That's Alameda County. And back in the 1960s, the very first, what we now refer to as health maintenance organizations, was opened. It was called Kaiser, and it still exists today. Now it's called Kaiser Permanente. And way back when, at this time, if you wanted to gather information about how many times someone went to the doctor or what conditions they came in or what prescriptions they had, it was virtually impossible to collect that data in an efficient way. You'd have to go to individual practices, individual docs, and get their records and their whole variability and how well they kept records. The great thing about an HMO, besides being kind of an efficient business model, is that patient records were all gathered in one place. So for the first time, tens of thousands of people went to one particular company, basically, who had different branches to get health care. I mean, that's what virtually everyone does today. But it was new then. And from a research point of view, it was fantastic because we had data that we could collect on thousands of people and trace them over time. And so these folks collected data from Kaiser at the time, and it's now referred to as the Alameda County study. And they have some of the initial linkages, empirical linkages, between basic behaviors that people do or choose to do and their health outcomes. And it's 7 particular health factors. And here's the quiz for you is I'm going to list these. There's just 7 of them. Just read them and just write down a number between 0 and 7, the number that you generally tend to do for yourself, okay? Between 0 and 7. So the question is, do you generally sleep 7 or 8 hours a day? Do you eat breakfast almost every day or most days? Do you not really snack between meals? Are you at or near your prescribed height-adjusted weight? This one's a little bit odd, but just make a subjective guess. Do you think that you're a little heavy or a little thin for your height? There's actual technical ways to figure that out, but most people can kind of guess for themselves. So yes or no, are you about the right weight for your frame? Have you never smoked cigarettes beyond just maybe experimentation? Moderate or no use of alcohol. Moderate use of alcohol is considered no more than 2 a day of any unit of whatever. Okay. And regular physical exercise. It's defined as more than a couple times a week. So think about it for yourself. Generally speaking, how many of these apply to you? Either write down a number or keep it in your head. And then I'll show you here in the next slide how the people in Alameda County fared given what they did. And one thing you should note is these are things that, with the exception of number 4, these are things that probably you can control, or you might think at least you could control. Number of hours of sleep, snacking, smoking, alcohol, exercise. There's some decisions involved there, right? It may be difficult. I mean, it's definitely difficult to do some of this stuff or not to do some of this stuff, but it's potentially under your control. So they had this data from thousands of people in Alameda County, and at the time, they just counted the sheer number, 0 to 7. At the time, they found that the more of these particular things that a person did, then the more healthy they currently were. And that was defined as the number of visits they tended to have on average over the course of a year. So people who did more of these 7 didn't show up as much. So arguably they weren't sick because they didn't go to the doctor, right? You did fewer of these, you made more visits. Also, not only did people have more visits if they did fewer of them, but the visits tend to be for more serious things. So those are what are called concurrent or cross-sectional correlations. It means this is the number of things you're doing right now, then right now generally what is your pattern of visiting the doctor. It's not really longitudinal, not over time. But they also looked at things over time. They had someone like you folks fill out this thing, and then I check with you 5.5 years from now, or I check with your records, or 9.5 years from now, and I see whether or not what you said today impacts your long-term outcomes. And there's been lots and lots and lots, I mean hundreds of publications using the data from Alameda County showing things like this. This is one of the things. So what you have here on the bottom are the healthful behaviors that you do or don't do from 0 to 7. They clump together 0 to 3 because very few people tend to do less than 3. It goes all the way to 7. And then on the left side is mortality. This is a fairly serious health outcome here. Are you dead or not, right? That's pretty serious. And you have some, either nobody died at the bottom, all the way to everyone died. A couple things to note. I've broken this one down by age cohort. So these are the ages. If you look here, this column here, this is the age that a particular person was when they wrote down about their health habits. And then you follow them, let's say about 10 years later. So for example, these people are now 85. These people are 75 to 84, et cetera. So these are the ages when they filled it out, and then they waited about 10 years and found out whether they were dead or not. They looked for basically death records. Okay. And the first thing you should notice is, regardless of the age, all of these lines are going down. Okay. All of these lines are going down. It's what's called a negative correlation. So the higher the number of health habits, the lower the amount of death. The fewer the health habits, the more the amount of death. And what's kind of remarkable is, even when people are relatively young, in terms of causes of death in the United States, even that there's still a trend that if you do more of these things, if you did 7, let's say, that there's virtually no chance that you're going to pass away, very, very little chance. And of course, that's more marked at older ages. I mean, and think how marked this is. Think about this. If you didn't do any of these things, if you did just maybe no more than 3 of those 7 things, you're virtually assured of dying. You have a 90% chance of dying here. I mean, you're 85 by this time. You're basically gone, right? But if you had done these relatively simple, basic behaviors, look at it, you drop all the way to almost just a little bit above 50%. That's what's called a really big effect size statistically. There's a huge effect from basic behaviors. So people who, particularly amongst the relatively speaking, the elderly, they can knock out their mortality. They can reduce their mortality risk by doing some basic behaviors. And this blew medical doctors away. Right? People who are in charge of fixing the machine, the idea that, wait a minute, so if people just do some basic stuff, they're going to live longer? Like, that's just, I don't know anything about what leads them to do these basic things. I'm not taught that in medical school. Why do people decide to exercise? Why do people decide to eat better? I don't know. Does anyone know? And so then the psychologist's like, we know. We have an idea. Maybe we should form an area called health psychology. And that's literally what occurred. Between when this study came out in the 1970s, and in about a decade, what was formed was the area of health psychology. Because of findings like this, that's showing just basic little behaviors have a huge impact on the ultimate health problem, death. Health is more than the body. It's fairly obvious, but I'll point it out anyway. So, for example, someone's lifestyle can affect their physical health. Are they a drinker? Are you a socialite and you're out not sleeping much? Your social relationships matter. Do you have social support? This is linked to stress, as you'll see later today or next class. Social support matters. If you have lots of stuff to do and you have someone in your life who can help you do part of that stuff, you've got less to do. You're a little less stressed, right? And there's ways of defining social support, which you'll get. Your personality matters. There's a huge linkage between being hostile, and this, unfortunately, we won't be covering in this class, but if you take health psychology, you can cover it. You've heard of type A personality. That does exist. We know that it used to be a whole bunch of factors. We now know it's basically being hostile. And hostility towards others has a huge connection to coronary heart disease. That's pretty psychological. The beliefs that you have, if you value health, you're going to do things that are healthier. If you don't value health, you won't. That's a psychological connection between the mind and the body. These kinds of things and others, they really need to be included in a full conceptualization of health and illness, and that's why we have this biopsychosocial view of things, and that's why we have health psychology. Questions so far? You get the gist, at least? This is kind of the appetizer for you to potentially take the main course class, which is Psych 251. Okay. So let me push on and talk about stress a little bit, that guy, and then eliminating that guy. Stress was the original topic of health psychology. Right now, if you open up an Introduction to Health Psychology textbook, there's 15 topics. When health psychology first started, there was 2 topics: stress and getting over stress, like eliminating it or coping, right? So I'm going to give you the bedrock of health psychology, but realize there's many, many topics, as I'll highlight for you next class. So stress is where it all began, and we know a lot about stress. There's tons of definitions, like what is stress? There's tons of definitions, and I'm giving you two here just to give you a sense of how people have defined it. The more comprehensive one has lots in it, each of which has lended itself to lots and lots of research over time. So the comprehensive definition of what stress is it tends to be negative. Okay? Some people talk about positive stress, or what's called eustress rather than de-stress. It's negative. I mean, that's a kind of a sub area, a small area to understand stress. So I don't want you to be confused by that. Stress is universally considered to be a negative emotional experience. It's accompanied by bodily changes, biochemical changes, physiological changes, thinking changes, how you act. And those changes generally are directed towards either getting rid of or altering the stressful event, or basically dealing with it, accommodating to its effects. There's a lot in here, lots of words, which gives you some sense of how kind of multifaceted or multidimensional stress is. There's a lot involved. A more parsimonious definition that's used in recent years is stress is a state in which the demands of the environment, whatever they are, however they're perceived, exceed the resources of the individual. So, and it's perceptual, as you've seen a little bit, but historically, we have to go back before people thought about psychology. But today, universally, people obviously believe that your perceptions of a situation matter with regard to whether you're stressed. It's how you view something, right or wrong. So these are a couple definitions just for your use. Different views of stress historically over time. I'm going to talk to you a little bit about Walter Cannon, who's considered one of the founders of the area of stress studies, really, about 80 years ago. He had a strictly physiological view of what stress is. Then we'll talk about Hans Selye, who offered what's called the general adaptation syndrome view of stress. And lastly, we'll talk about Richard Lazarus and his psychological appraisal view. Lazarus is the guy who basically interjected psychology fully into a view of what stress is. Prior to Lazarus, views tended to be almost entirely bodily based. So Walter Cannon, he did his work in the late 1920s into the 1930s, and you may have heard the phrase fight or flight response. You may or may not have heard this, but a fight or flight response. The basic idea here is that when you encounter something threatening in the environment, a lion walks in the door, I guess that would be threatening. I mean, it would be threatening to me. Generally, you have some sort of physiological response to that. Number one, it's unusual. Number two, it's a lion, right? And Cannon's basic point of view is the body readies itself to either run, like that way, or attack it, right? Take it head on. I can tell you what my choice would be. I'd be running over all of you. But that's the idea of fight or flight, right? That you're either going to fight it or you're going to run from it. Either way, according to Cannon, your body needs to physiologically ready itself. It has to be ready to be able to move relatively quickly. And he spent quite a bit of time detailing how the body changes in response to a threatening stimulus. So you're going to attack it or flee it. Now the amount of bodily response or physiological response, according to Cannon, depended on the nature of the stressor. And so, he wasn't arguing necessarily dependent on your perception of it. He argued that, well, if it's a lion walking in here versus a cat, I suppose. I'm not sure I would define the cat as a stressor, but a smaller wild cat, maybe, that the nature of the stressor itself will change the degree of physiological response. And he detailed the various things that happen in your body when you do encounter a threatening stimulus. So stress would motivate the sympathetic nervous system. It kicks into gear. The endocrine system as well. Secretion of catecholamines. Your heart rate tends to go up. I mean, think about when in a stressful moment, someone runs out in front of your car and you're driving. You slam on the brakes. Thankfully, everything's cool. But still, there's that moment where you're like, right? Your body is reacting. Your heart rate goes up. Your blood pressure and blood sugar tends to spike. Your blood circulation tends to go down. People talk about being clammy after really frightening events, because basically your blood is being sent from your limbs to the central, I don't know, what do you call this, the trunk? I don't know, there's some word for it. Let's say trunk. The trunk of the body. The blood basically leaves the limbs or goes to the legs. So to ready the legs to run, right? More blood goes to the muscles to ready them to either flee or fight or flight. Now, certainly the stress response is adaptive because you're going to get out of there and avoid being eaten, or you're going to end the lion. But it's also destructive because your body isn't set up to constantly be in a state of stress. Okay? We're not made that way, for better or for worse, generally for worse. So if you're in a chronic stress situation, then all of these levels are at chronic levels. And by definition, chronic means all the time. And that's wearing on the body. It wears the body down. In that sense, stress is associated with all sorts of health conditions. Prolonged exposure to stress wears one system down. And we all know that. At the end of a semester, you're exhausted, collapse, right? People get sick at the end of a semester oftentimes. It's cumulative stress. That's Cannon's view. He's kind of the bedrock founder of stress studies. I'll talk a bit about Celia, and then we'll be done for today. It's pronounced Celia. He's from Northern Europe, I believe Sweden. And he used the word stress. He actually took the term stress. Celia is the guy who coined the term stress, right? Cannon didn't use the term. Hans Celia, the term we use, almost stressed out. You can thank this guy, Hans Celia, for giving us that term. And he took it from engineering, stress of metals and things. And in fact, I think someone did an analysis of what he was trying to make an actual analogy of, and it probably should have been strain or something. So we'd all be strained out. He got the word a little bit off, but he adopted the term stress. And he's similar to Cannon in that he believes that when an organism, that could be an animal, including humans, is exposed to a stressor, it mobilizes for action. It readies itself to do something. But he believed that the actual bodily response was non-specific with respect to the stressor. That's a quote from him. Non-specific. In other words, the bodily response is the same regardless of whether a lion walks in here or a small wildcat. The physiologic response is exactly the same. It's not specific. So regardless of the source of the threat, what type of threat it is, the physiological response is the same. Thus, he calls this general adaptation syndrome. This is where we have the title, general adaptation. The body has this general adaptation when there's any type of stressor. So it's just a nuanced difference, really, from Cannon. And there's a couple other things that he offered, which I'll show you here in this next slide. Celia basically argued that he offered us these stages that an organism goes through when it's responding to a stressful situation. First, we have what's called the alarm phase, where you become mobilized, your body readies itself to act in some way. There's then the resistance phase, where you make active efforts to cope with the threat, and they may or may not be successful. I mean, you're trying, but they may not work. And then if you keep resisting, you're finally going to enter an exhaustion phase where you've resisted as long as you can. And this occurs if the organism fails to overcome. Basically, they fail in step 2. They fail in resistance. And so their physiological resources are just exhausted. They're gone. And this is a key point. That it's this third phase, according to Celia at least, it's the third phase. It's the exhaustion phase, which is responsible for the bodily damage that occurs. And that lays oneself open to disease. Whereas Cannon held that the alarm stage, even the first couple of stages, just being under alarm or working at solving the stressor, that itself is damaging. So they said no. Our bodies were developed evolutionarily to have this response, to try to deal with stuff, and it's really only from repeated efforts to solve the problem that we have a long-term problem. So it's a slight difference. Both of them, I think I would just hammer home to you, is neither of them really have a role for psychology here. What if I spent my childhood working at circuses, right? I'm like really used to lions, right? So it comes in here and it's like, I'm not freaked out at all. Right? I mean, I may be stupid because I don't know this lion, but still. Obviously, what you see as threatening the environment depends on you, right? And how you see things. And that's ignored by these first two models. And the final model does ignore that, which is the more kind of modern view of stress. I just mentioned the second point here, which is that these first two models aren't psychological. Stress is in the eye of the beholder. For example, my nightmare could be just a challenge for you. Or like a math exam for me might be a nightmare because I'm not good at math, let's say. And you're like a math whiz, you're like, bring it on, I want the exam, right? It's the exact same stimulus. It's an exam on a certain day, right? You prepared, I didn't. Or I don't feel like good at it, you feel you're good at it, right? So obviously, it's in the eye of the beholder. It's ignored in the first two models. The next model, by Lazarus, gets into that, and we'll talk about this next class. Thanks for listening. I'll see you on Wednesday.